Our next topic is goal-directed fluid therapy by Dr. Neeta Bose Madam, and chairpersons for these are Vidyananda Chavan Sir, Dr. Amruta Date Madam, and Dr. Nikhil Akhude Sir. I request Dr. Rupesh to escort all members to the dais. Dr. Vidyananda Chavan Sir is HOD Anesthesia and Critical Care at Ashwini Hospital, Solapur, and practicing anesthesiology since last 31 years. Dr. Amruta Date Madam is HOD Anesthesia and Critical Care at Seva Sadan Hospital. She is a Vice President and Founder Director at Seva Sadan Hospital. Dr. Nikhil Akhude Sir is Senior Consultant Intensivist and Anesthesiologist at Ushakal Hospital, Sangli. We welcome you all. Yes, ma'am, you can start.
Welcome all. We have Dr. Neeta Bose, Madam, who is an Associate Professor with GMERS Medical College, Vadodara, and a lot of laurels to her accreditation. So, without a further delay, let us hear, ma'am.
Sure.
Thank you so much.
Thank you, ma'am. Thank you. So, this is more like a theoretical topic, but we can take some take-home messages from it. And thank you at the outset, the organizers, for calling me, and I'm really honored to be here amongst the August gathering. So, regarding goal-directed therapy, I just start with a case. There is a male 24-year-old patient has undergone a road traffic accident. There is tachycardia, the BP is low, there is a, this patient is, this kind of scenarios we are seeing. There is a scalp wound, and there is a deformity of the left arm, and there is a patient being posted for the femur surgery and wound debridement. So you can understand this is one of the patients where our fluid is going to go in. So what is going to be your choice? I mean, as Sir said, the PGs are not there, but then you can always answer it for yourself. So what can be the fluid of choice for resuscitation amongst? Obviously, some of the choices are not at all valid here. It can be the normal saline or the ringer lactate, and we'll see how normal saline comes about. So what is true or what is bad about normal saline? Is it always, it is a normal, or is it a abnormal saline? So one of the things which is very, we have to be wary with the normal saline is when you push too much, maybe 1 or 2 is not okay, is fine. But when we are going beyond 2 liters, then this problem of the metabolic acidosis, hyperchloremic metabolic acidosis starts creeping in. So the concept of balanced solution has now come into the being, as many of you will be already aware of, and the term balanced is applied to fluids which are not giving the problem like the normal saline, that there is not too much of the chloride content. So for what do you mean by balanced? So balanced will be that it has to have the minimum effect on the acid-base equilibrium and the electrolyte content. So in the fluid, you have to see what is the strong ion difference. It should not be more than the normal bicarbonate level, right? Or it should not be lower. Then it is particularly a proper electrolyte balanced fluid, and their chloride content is something which we should look at. It should be less than 110. Of course, normal saline has got much more than that, right? So the few things which affect the pH of our fluid, our body fluids, is the PCO2, the non-volatile weak acids, and the strong ion difference, as I said. So all the IV fluids that we give, and when we give in large amount, it is going to make a difference on the content, the electrolyte, and the changing the pH also. So if your strong ion difference of IV fluid, as I said, is more than the plasma, it will be more towards the alkalosis. So I have given a comparison, like the stereo funding, you can see that's an isotonic balanced solution which has a chloride content which is more than 110, but SID is around 24. Ringer lactate has a lower chloride content, but SID is 24. And plasma light has a more of an alkalizing effect. So you can have, whenever you are making a choice, you can choose. Remember the saline, what is the problem with it is, it creates a renal, lowers the renal perfusion, and the hyperchloremia may actually have a problem on the renal cortical perfusion also. So although this is a fact, and this the chloride content is more, but only very few studies have actually proven the misbenefit of the normal saline, as you can see in the SMART trial. So these are the comparisons, I'm not going into it. Now what about the colloids? Like after thinking about the crystalloids, what about the colloids? Colloids have been now less used in resuscitation, although it was a very favorite drug for us in the OTs. But it has been associated with acute kidney injury and 90-day mortality. So you have to be wary if you are going beyond certain volumes, at least not more than 1 liter should be infused at a time. So this is just a comparison of the crystalloids, colloids and normal saline. Obviously saline falls out with the high chloride content because of the risk of the hyperchloremic acidosis. Now how much fluid would you give, right? So there is now this concept of balanced resuscitation which is creeping in. Earlier it was more than 2 liters, it was at least 2 liters, but it is now just 1 to 2 liters, and then you check for the response. Even the ATLS in a trauma care patient are advising to give in a 70 kg 1 to 2 liters initially. These are the ways how you can give, that is the cannula. Now what is this importance of this IV fluid administration is? This IV fluid can be used either as resuscitation or replacement or maintenance. And there's also one concept known as the fluid creep. Like that is when we are doing all this resuscitation, we just keep calculating the amount of fluids that we are giving. But we are using so much other fluids as diluents, drug diluents, and keeping the catheter patent and all that. So whenever you calculate the positive or negative balance, please make sure that you are calculating this. I'm not going into the detail, but there are 4 Ds of this fluid management. That is the drug, the dosing, duration, and the de-escalation. So it should not be inappropriate, the timing should be appropriate, and you can use a combination therapy when you are using the correct drug. And I said the inappropriate can be if you use too much of saline, hyperchloremic metabolic acidosis. Now dosing is another thing, is how much to be used. Now it is said that in a 70 kg man, you do not go beyond 5 liters, but not less than 3 liters. Duration, it has to be, you have to stop. See, always remember, after initial resuscitation, when you are achieving the parameters, or when your cardiac output or your normal lactates has been achieved, that is the time you have to stop and you have to de-escalate also. Now, why this goal-directed therapy has actually creeped in, like the measurement of the cardiac output and all that, is the enhanced recovery after surgery protocols are being increasingly applied in the perioperative settings. So now in the preoperative time, what are the factors which will affect the volume status? It is the NBM status. If the patient is NBM for a long time, that fluid has to be covered. If there is any preoperative hemorrhage, if there's a trauma patient or any disease status where patient is losing the water, all this will be calculated when you are going to give fluids the preoperative intravascular volume. So why you want to monitor these patients? Why you want to monitor the intravascular status of these patients? Just to get the correct tissue perfusion. So you don't go under and you don't go over. So hypo and hypervolemia both can be dangerous. We say, okay, keep on pushing fluids, but what we are actually doing is creating a level of hypervolemia which will actually suppress the capillary refills. It will suppress the capillaries and tissue perfusion can get hampered. It has been seen that it leads to interstitial edema and local inflammation. There can be problem in the reparative process, and there can be problems in the wound healing and wound infections too. So it's a U-shaped curve. You want to be somewhere, between here in the euvolemia status when it is, when you want to calculate the intravascular volume status. Now this is the most poorest form of the cardiac output that we say, whether is it the correct way to monitor the urine output, the normal values and all. But it is always not a sensitive indicator, especially in acute care settings where renal injury is also predominant. These are some of the volume status measurements we are using. We do the clinical tests, we do the laboratory tests, the CVP, the pulmonary artery wedge pressure, etc. So now we are going to talk about the dynamic parameters. These are all the static parameters. Static parameters, just remember one thing, is static is that at one time you take a measure. But that measure does not give you much information. When it is a dynamic measure, you do something to the patient and you repeat the measurement. And that is what is important for us when we look at the goal-directed therapy. So not all patients who are fluid responders will actually require fluid volume expansion. And they often have difficulty, clinicians will have difficulty in estimating the preload condition, right? So so decision to administer the fluid will be basically based on whether there is going to be any hemodynamic improvement in the patient or not after giving the fluid, and there is no risk associated with it. Okay. Earlier it was, if you remember, the early goal-directed therapy, the reverse protocol, where CVP, mean arterial SVO2 and urine output was being measured, and slowly we are moving away. The early goal-directed therapy did help, but it was again on some static parameters. So, okay. So goal-directed therapy is usually used for a term when we are talking about the fluid therapy in the perioperative settings, when we are measuring the cardiac output or some surrogate markers of the cardiac output. So basically it is to maximize the tissue oxygen delivery and achieve the ideal hemodynamic status. So if I talk about now, do I measure cardiac output in each and every patient? No. But there are some group of patients, like suppose patient is a case of APR, there is a lot of fluid loss, third space lossing, and gut is open. So these kind of patients may require cardiac output monitoring. If we do not do, these are the various organ injuries, pulmonary, cerebral, myocardial, hepatic, all these organs can get involved if you go for over the resuscitation. If you see some of your big GI cases that we do, the patient is fine in the first day because we have replaced the fluid. This is the kind of X-rays we start seeing in the coming days. So where will that extra fluid go? It goes to the lungs, right? So that is where the term comes, is that you monitor the intravascular status, give the fluids according to the need of the patient. So there are certain questions which can be answered. I'll be going to it. As I said, now there are studies being done about the restrictive and the liberal fluid therapy. More toward the world is changing more towards the restrictive. Not on the first day, but yes, on the second and third day when your acute resuscitation phase is over. Although there will be some patients who are still vasodilated, so you can give inotropes and vasopressors to the patient, rather pushing in more and more fluids without monitoring the cardiac output. So there can be a lot of gut-related problems, and splanchnic perfusion can fall only with the 10 to 15% decrease in blood volume, and this will actually overlast the period of hypovolemia also. So the key techniques are measuring the stroke volume variation, the pulse pressure variation, the cardiac indices, and these are some of the studies which have proven that it is better if you measure the cardiac output here. Now, main thing is, when you assess intravascular status, we also would like to know the fluid responsiveness, to the response to the fluid challenge, right? Fluid challenge is usually something like a 500 ml, I'm not going into the detail, but you do not give 2 liters of fluid, but you give 500 and you see the response, right? That is what is fluid responsiveness about. So the dynamic indices, before I go into dynamic indices, what is the preload? We all know the cardiac output is equal to the heart rate and stroke volume. It is determined by the preload, afterload, and the contractility. So remember one thing is, this is the Frank-Starling curve, and all the dynamic indices are dependent on this particular curve. When I give some fluid on this part of the curve, the ascending part of the curve, there is going to be a positive effect. But the same change, the same amount of change or the same amount of fluid, if you give it at this part, that is the flat part of the curve, what is going to happen? There is not going to be any change in the stroke volume or the cardiac output. So that is where this kind of monitoring does help us. So fluid responsiveness means that it has to increase by at least 10%. And generally it is seen, if you do not do these kind of monitoring, only 50% of the patients are really fluid responsive. So this is again the Frank-Starling curve. I won't dwell into it. So it depends upon the contractility and the diastolic function as well. Whereas is your curve here, or is your curve somewhere down there? Okay. So that will also make a difference in the amount of stroke volume which is being produced. So fluid optimization concept based on the stroke volume monitoring is, if we give small boluses of fluid, if you are here on this lower part of the curve, there's a 10% increase in the stroke volume, it is beneficial. Give more than 10% beneficial. The moment your increase in stroke volume is less than 10%, that is the time you can actually stop. So CVP and pulmonary artery wedge pressures are actually poor predictors of fluid status because they are pressure measurements, not volume measurements. Now the cardiopulmonary interactions which are taking place is when you give a positive pressure wedge, most of our stroke volume or cardiac output measurements are done in ventilated patient. Okay? So in positive pressure what happens is the pressure in the lung rises, intrathoracic pressure rises, the SVC will collapse, preload will decrease, and there will be a transient decrease in the cardiac output, but ventricular preload decreased and afterload is also increased because of the intrathoracic pressure. So what happens? Your systolic blood pressure actually increases with the increase in the thoracic volume. So, using the dynamic approach, if you see here, the systolic pressure, pulse pressure, aortic blood velocity, they will be maximum at the end of inspiratory period and minimum at the expiratory period. So these are, as I told you, systolic pressure variation, pulse pressure variation, stroke volume variation, and the passive leg raising test. So I'll straight away go to this thing. I'm not dwelling. You require specialized monitors, the PICO and LIDCO. PICO takes help of arterial line and it takes help of the thermodilution technique also. LIDCO are the pulse contour devices which takes help of the arterial line, measures the area under the curve and multiplies it with the heart rate, so we get to the stroke volume. So just know the physiology behind it, that the difference between the stroke volume max and the stroke volume minimum with the phases of the inspiration and expiration, you have to calculate to get the stroke volume variation. In short, the changes of the respiration, how much change it is making in the stroke volume, that is known as the stroke volume variation. If it is large, simply, if it is large, that patient will benefit with fluids. If it is small, I'll get you the values. If it is small, then patient will not benefit with the fluid that you give. So straight away I go for this, the effect of blood pressure on various flows, that is the aortic flow, the pulmonary artery and the vena cava. Pulmonary artery and vena cava flow is decreased, aortic blood flow is also decreased. So as you can see here, systolic pressure variation and pulse pressure variation, you can see the swings in the arterial waveform, and that will be calculated by an algorithm and the values will be given. Generally, the line of reference is taken at the end expiratory pause. You measure the distance to the maximum and measure the distance to the minimum, and if this maximum to minimum difference is more than 15 mmHg, the patient will be responsive. Similarly, with the pulse pressure variation, if it is low, then there is hardly going to be a benefit with the fluids. You have to give inotropes. If it is pulse pressure variation is a high, pulse pressure we all know what it is. If it is more than 13%, there will be benefit. I'm not going to that algorithm, but again, remember the cyclical changes in the preload induced by the mechanical ventilation. In the steep portion, if you are giving the, if you are measuring the stroke volume variation, you will have a more response here, whereas in compared to the flat portion of the Frank-Starling curve. So the algorithm says, hey, does my patient need an increase in the SV or cardiac output? Is the arterial pressure tracing accurate? And does my patient make significant respiratory effort? See, another one thing is why this algorithm is there is if your tidal volumes are too low and if there is an arrhythmia, this interpretation can go wrong. Remember, if you want swings in the pressures, you need to have a good tidal volume that is at least 8 ml per kg. Then only this will be effective. So then you measure what is the SVV and whether you need to give fluids or not. Other surrogate measures are aortic blood flow, which is measured by the esophageal Doppler, subaortic peak velocity by the echocardiography, and the stroke volume by the pulse contour analysis. There is also, if you see, the plethysmographic variability index. Have we seen the pulse oximeter on the monitor, right? What we see sometimes, if the patient is volume depleted, there are swings in the plethysmography, right? And these swings can be used to measure through an algorithm to give the plethysmography variability index. This becomes a bit little simpler, but again it has got its own limitation because in very low flow states you may not be able to get a waveform. So this is also one of the things which is coming up, that is the plethysmography variability index, which can give you the, if it is more than 17%, that patient will be fluid responsive. There are limitations, as I said, that cardiac arrhythmias, high frequency ventilation, low tidal volume, and if there is a open chest surgery, so many limitations are there. You have to look at it, and in short, with SPV, PPV, SVV, these are the various numericals which will tell you whether patient is fluid responsive or not responsive. Okay, so these are all different calibration. Preload does not mean preload responsiveness. It does not always mean the need for fluids. So sometimes something like the size of tidal volume or the passive leg raising test can help you determine whether there is going to be any responsiveness with this preload. Okay, there is another end expiratory occlusion test, which is if it is, you have to stop the respiration, make the intrathoracic pressure rise high, and if there is a cardiac output change more than 5%, then there can be, patient can be responsive. So I'm not going into detail, this I've already covered. There is something known as the mini fluid challenge test. Again, it is taking the use of the velocity time index, which is measured in the transesophageal echocardiography. Passive leg raising, give me some time for the passive leg raising. Just quickly I will go through it. So passive leg raising is what is basically you have to raise the leg up, the volume from the lower limbs and the splanchnic circulation go to the thoracic circulation. So it acts like a volume challenge. This volume challenge is actually not there. You keep it for 60 to 90 seconds and then again make the patient straight. So what you are trying to do is you are giving a auto fluid challenge, but not making the patient heavy on the lungs because you're returning the patient back into the position. So there are the fluid challenge and the passive leg raising. If it's more than 10 to 15% rise in the stroke volume in 30 to 90 seconds, that means it is preload responsive. So there is, I'm not going to detail, there are a lot of benefits with this, and quickly I will finish this part of it. Another thing is the collapse of the IVC. The IVC collapsibility index is also there. If it is more than 15%, it is very quickly measured at the bedside. But again, if there is abdominal condition and all, sometimes it is very difficult to view the IVC. So more than 15%, patient will be volume responsive. So I'll skip all this. There is an ultrasound guided protocol to look at the B lines of the lung ultrasound, and you can measure the moment B lines start appearing or they become more than 15 in all your scans. There is a time when you can actually stop giving the fluids, right? So these are the clinical and lab parameters that we are doing daily, day in and day out, and the rest of the things which I have talked, the mini fluid challenge, SVV, PPV, and the tidal volume challenge. So these things can be used. It has been seen through various trials, that the relief trial and optimized trial and all, that goal-directed therapy, if you are using, especially for certain indicated surgeries, it will help. So there is like it is said now, you look at the surgical risk and you look at the patient risk both, and you aim for only 1 to 2 liters positive, not more than that, and then come down the moment you are achieving your parameters. Okay, and this is a ROSE concept. I'm not talking about it, but this is something like resuscitation, optimization, stabilization, and de-escalation or the evacuation phase, which is also getting an importance these days. So I thank you for the patient listening, and sorry for overshooting the time by a minute.
Thank you, ma'am. It was a really informative and helpful topic for all of us in our day-to-day practice. Thank you once again. Now I will request chairpersons to felicitate Dr. Neeta, madam.
There's a practical tip there though. For the bedside, we can always have ABG handful.
Yes.
With the lactate monitoring for tissue perfusion.
Yes, yeah, that initially I had said, like moment you see your lactates and the pH coming back to normal, that is the time when you can actually stop the fluid, excess fluids.
Excellent lecture, ma'am.
Thank you, ma'am.
We will have a short tea break after this. And after tea break,